Hi, everybody. We have seen actually your performance in the examination held on Wednesday. I think the first mark is around 37 out of 40. There are two people, actually two students who have got that mark. One is Meena, and second is I think Prithvi or Prithviraj. I don't remember the name exactly. And there are nearly about 18 to 20 people who failed in the examination. That's really saddening. Okay, I thought actually you people will do well. I have been telling you about the examination for the past 2 to 3 weeks now, and yet performance is not up to the mark. And congratulations to those people who have done well. So that's 37 first mark people. And the rest of you gear up, read well for the next examination. Okay. So we have already seen about the primary angle closure, primary angle closure suspect, and primary angle closure glaucoma, and primary angle closure, these three things. And traditional classification, I have already mentioned it's latent glaucoma or so the traditional classification, as I already mentioned, it is a latent period and also the stage of constant instability or intermittent subacute glaucoma and subacute acute congestive stage of angle closure glaucoma, chronic congestive glaucoma, and absolute glaucoma. We have seen actually various signs and symptoms and also the modalities of management of these cases. So, absolute glaucoma also has. Now we go on to actually secondary glaucomas. These things, they can be given as actually a short notes for you people in the examination, maybe 4 marks question. It depends actually on the examiner or who sets in the paper. So the definition of secondary glaucomas are, they are actually a group of disorders in which the intraocular pressure is raised and it is associated with some primary ocular or systemic disorders. So when you examine the patient, you will see actually intraocular pressure and the manifestations of intraocular pressure on the ocular structures, and also the way other disorders which have caused the rise in intraocular pressure, ocular disorders or systemic disorders. So both the things clubbed together you will find whenever you examine the patient. And secondary glaucomas, either they can be an angle closure glaucoma or an open angle glaucoma, and they usually occur in eyes where there is a predisposition for the particular secondary type of glaucoma. Okay. Where actually you have high risk factors and family history of the glaucomas, maybe a primary open angle glaucoma or an angle closure glaucoma, or a corticosteroid preponderance or high responders of corticosteroids. And treatment depends both. We will have to reduce the intraocular pressure by various means, medical means or laser or surgical. And second thing is you will have to treat actually the disease which is causing actually the rise in intraocular pressure. So classification, again I have mentioned already, secondary open angle glaucoma and secondary angle closure glaucoma. And depending upon the mechanism of rise of intraocular pressure, secondary open angle glaucomas, the aqueous outflow can be impeded or blocked at pretrabecular by a peritrabecular membrane, the pretrabecular region, and a trabecular clotting with the rather lens proteins or macrophages which have phagocytosed the lens proteins, or a trabeculitis, edema of the trabecular meshwork, or a scarring of the trabecular meshwork. All these things actually they can cause an impediment for the passage of aqueous through the trabecular meshwork, giving rise to actually raising intraocular pressure, edema and scarring. Post-trabecular, there can be an elevated episcleral venous pressure, which can give rise to actually post-trabecular causes for rising intraocular pressure, and secondary angle closure glaucoma, which may or may not be associated with pupillary block. So, etiopathogenesis, secondary glaucomas, etiopathogenesis, they can be actually inflammatory glaucomas, lens-induced glaucomas, pigmentary glaucomas, neovascular glaucomas, pseudoexfoliation, aphakic glaucoma and aphakia or pseudophakia, steroid-induced glaucoma, traumatic glaucoma, and glaucoma associated with intraocular tumors, and glaucoma associated with intraocular hemorrhage. So, glaucomas, inflammatory glaucomas, glaucomas associated with active uveitis. So, the inactive uveitis, what happens is actually the blood aqueous barrier is altered, giving rise to actually a lot of proteins in the aqueous, and the aqueous becomes thick and plasmid, and it passes into the through the trabecular meshwork. Actually, it becomes very difficult, and that's the reason actually the aqueous gets collected in the anterior chamber, and that gives rise to actually raised intraocular pressure. And in case of chronic uveitis, with post-inflammatory glaucoma, that is post-chronic uveitis cases, in chronic uveitis cases, in active uveitis again, there can be actually a synechiae formation, annular synechiae, or a membrane can form actually in the pupillary region, which impedes actually the passage of aqueous from posterior chamber to the anterior chamber, and thereby giving rise to a raised intraocular pressure. And also, so it's the collection of aqueous in the posterior chamber because of the annular synechiae or because of the membrane which forms actually the pupillary region. So the flaccid iris, it comes forward and it can give rise to actually an positional synechial closure in the angle, and later on a positional closure of the iridotrabecular meshwork, or it can be a synechial closure of iridotrabecular meshwork, giving rise to a glaucoma again. Okay, and hypertensive uveitis, because of actually the plasmid aqueous, so there can be actually raised intraocular pressure. That's what we call a hypertensive uveitis. Glaucomatocyclitis crisis and Fuchs heterochromic cyclitis, these two things have been covered actually when we are talking about uveitis. So these are actually inflammatory secondary angle closure caused by pupillary block. This is actually the gonioscopic view where you see where there is no, the angle is closed with anterior posterior synechiae, with iridotrabecular meshwork position. And secondly, we have actually these are actually the posterior synechiae, what we see here, and almost annular synechiae they have one. Okay, so lens-induced glaucomas. So the lens-induced glaucomas, they can be either open angle glaucoma or an angle closure glaucoma also. Phacomorphic glaucoma or phacotopic glaucoma, these things actually they are angle closure glaucomas. The open angle glaucomas are phacolytic glaucomas, lens particle glaucomas, and glaucoma associated pathogenic toxic uveitis. And glaucoma associated phacoanaphylaxis. These things actually are actually open angle glaucomas, especially phacolytic and lens particle glaucomas, and they are more commonly seen actually. Phacomorphic glaucomas, what happens is actually here the lens will be swollen either by an injury or because of its maturation. Mature cataracts actually, mature or hypermature cataracts, you get this. And there will be more apposition of the anterior surface of the lens with the pupillary margin. So that impedes actually the aqueous to come into the anterior chamber, thereby giving rise to its collection in the posterior chamber, and the iris lens, the flaccid iris, it comes forward, it's pushed forward, and there will be adhesions between actually a portion of closure between iris and also the trabecular meshwork, giving rise to a angle closure glaucoma in case of phacomarked glaucoma. And phacotopic variety actually here, the spirophakia, when the lens is small and it blocks actually the pupillary region, and a subluxated lens or a dislocated lens when it blocks actually the pupillary region. So this can also give rise to an impediment to the passage of aqueous from the posterior chamber to the anterior chamber, and giving rise to an acute congestive glaucoma. Okay, so the symptoms will be the same as an acute congestive glaucoma. The patient lands with severe pain, redness, and the mid-dilated pupil. All these things will be there, and the lens will be a mature or hypermature cataract or the spirophakia, or a subluxated or dislocated lens in the pupillary region can also be seen in these cases. Okay, so the management of case of phacomarked glaucoma actually is we actually treat the patient with initially to reduce the intraocular pressure, which is very high, around 40 to 60 millimeters of mercury. So we give intravenous mannitol and acetazolamide 250 milligrams 3 or 4 times per day. And also we give steroid local drops actually to reduce the inflammation of the iris and everything. And then we try to remove actually, we do an extracapsular cataract extraction by way of small incision cataract surgery or a phacoemulsification, remove the lens, and then put in actually a PCI oil. So sometimes actually we may do a YAG capsulotomy, YAG iridotomy to reduce the intraocular pressure. The diagnosis of phacomarked glaucoma, it is done actually whenever the eye which is actually inflamed, you see a hypermature, mature cataract, and at the same time a pupil which is almost a little bit dilated, and pupillary grip of the lens will also be present, and there will be corneal edema and AC flare, and all these things will also be there. When you examine actually the other eye, the eye will be quiet and there will be, the angle will be open. Okay. Next we have actually phacolytic glaucomas. Phacolytic glaucomas, normally they are seen in hypermature cataracts or a Morgagnian cataract, whatever it is. And here actually the lens proteins, so they see through into the anterior chamber through the intact capsule. And the trabecular meshwork actually it is clogged by the lens proteins, and also the phagocytes, the macrophages which phagocytose actually the lens proteins, and also inflammatory debris. So these three things actually they block actually the trabecular meshwork, giving rise to an increase in intraocular pressure. Okay, so that's the reason actually the patient comes with again severe pain and also raised intraocular pressure, and eye will be very congested. That's conjunctival tension, circumciliary congestion, all these things will be there. The intraocular pressure usually will be around 40 to 60 millimeters of mercury, and you see actually a pseudohypopia sometimes in case of phacolytic glaucoma. Okay, so the management is to reduce intraocular pressure with mannitol or acetazolamide or all these things, and local timolol muriate, all these things also we use actually to reduce it. Local steroid drops actually to reduce the inflammation, and then we do actually a extraction of the lens and put in an IOL. So that's how actually we are looking at actually phacolytic glaucoma. Lens particle glaucoma, actually this is another variety where the trabecular meshwork is blocked by lens particles. So this usually occurs in an accidental or a planned extracapsular cataract extraction, where actually the lens matter is left behind. So this actually blocks the trabecular meshwork, gives rise to another open angle glaucoma. So when you examine the patient, actually the patient may be aphakic, or he may have an AOL, but there will be a raised intraocular pressure. The aqueous may contain white particles, lens particles, and you may see actually the retained particle matter somewhere in the pupillary region or in the angular, the AC or whatever it is. So these are the things actually we see on the slit lamp biomicroscopic examination. So what we do is we reduce the intraocular pressure by way of medical management, and then actually we try to aspirate, the AC wash will be done to remove actually whatever little particle matter is there, that we try to aspirate it out. Usually these people, they respond well. And the fourth one is glaucoma-associated factors and ducts uveitis. This lens matter which is left behind in actually the AC while doing the cataract surgery, it may cause actually the inflammation of the uvea. It can cause an iridocyclitis, acute iridocyclitis, and if it is left for a very long time, a chronic uveitis can also occur. So this can give rise to a raised intraocular pressure. So what we do is actually we try to reduce the inflammation by giving steroids, and try to reduce actually now. నేను క్లాస్లో ఉన్నానమ్మా 10 నిమిషాల తర్వాత చేస్తాను. So we use steroids, and also we reduce actually the intraocular pressure by doing it by giving actually anti-glaucoma medication. Usually medical treatment will do, and suppose if it is not coming down, in such cases you may go in for actually vitrectomy. Glaucoma associated with phacoanaphylaxis. This usually occurs in cases where the patient underwent a ECCE some time back, and later on the retained particle matter actually acts as an antigen, and the antibodies will be formed, and the antigen antibody reaction and inflammation of the iris will be there, and that causes actually phacoanaphylaxis, and the patient may go in for actually a glaucoma, secondary glaucoma in these cases. Okay. So these are actually various phacogenic lens-induced glaucomas, and usually we may ask you about phacomorphic glaucoma or phacolytic glaucoma. This lens particle glaucoma also sometimes actually we give it as a short transposition, and we have to be thorough with it. And this is phacomorphic glaucoma. As I said, this is a mature cataract, and the pupil is mid-dilated, and you see actually there is a pupillary grip over this thing, and the AC is shallow, the periphery is shallow. See, this here also actually is almost, and macrophages plugging the subaqueous meshwork, and this is again hypermature cataract leaking proteins into the anterior chamber. And this is again hypermature cataract and floating particles, either lens particles actually in the anterior chamber in an eye with phacolytic glaucoma. And this is again a phacolytic glaucoma, very large pseudohypopia, hypopia. This is pseudohypopia. So this is also a case of phacolytic glaucoma. So next we have actually the pigmentary glaucoma. So this pigmentary glaucoma is also a secondary open angle glaucoma due to pigment release, and also pigment going and blocking actually the retinal atmosphere. Seen in usually young males more predominant when compared to ladies, and with myopia. So these people, they have high myopia. 50% of the patients with pigment dispersion syndrome actually also they develop glaucoma. Pigment dispersion release is by usually the mechanical rubbing of the posterior layer of iris with the joint of iris. So that's the cause actually for pigment dispersion. Okay. The clinical features they are similar to actually primary open angle glaucoma. So they may have actually they intermittently present, or sometimes they may be seen continuously also. And on examination, pigmentary deposition in the anterior segment stretches So on the pigment dispersion over the endothelial surface of the cornea, it's known as Glaucoma-VI spindle. In the angle, actually, over the trabecular mesh, like you see, that's the sample is line. And you see actually radial slit-like transillumination defects in the mid-periphery of the iris. So that is actually the pathognomonic feature. We show you photographs. And 50% of the patients of this pigment dispersion syndrome, these people, they develop actually the glaucoma. The management is medical management. Usually they respond, and if not, actually we try to do a trabeculectomy. So this is actually a pigmentary glaucoma. That's what we see, and sample is this line. Sorry, this is actually Glaucoma-VI spindle, and transillumination defects in the periphery of the iris. That's what we see here. And this is actually a pigmented trabecular meshwork, and this is sample is this line. Okay. So next is neovascular glaucoma. It's an intractable glaucoma due to neovascular membrane in the angle of the anterior chamber. And it is because of extensive retinal ischemia secondary to the proliferative retinopathy, central retinal vein occlusion. Eels disease is retinal vasculitis, usually seen in males. And sickle cell retinopathy, we have in Jalar-Patria sickle cell retinopathy, sickle cell anemia, this we come across. And these are the causes for neovascular glaucoma. And presence of neovascularization of the iris and consequent fibrosis leads to chip-like adhesions of the iris to the cornea. So that gives rise to an intractable glaucoma. Okay. And there are very clinical stages. There are various stages: stage of rubeosus iridis, open angle glaucoma stage, and secondary angle closure glaucoma also can occur. And the management of these cases is photocoagulation, retinal photocoagulation, pan photocoagulation too. And sometimes we do a cryotherapy to eliminate the stimulus for neovascularization, so that actually retinal ischemia will not be there, and there won't be neovascularization. Trabeculectomy with the antifibroblastic drugs can also will be done in these cases, because we say neovascular glaucoma is tough to treat. So the medical management usually will not be efficacious, and trabeculectomy with the antifibroblastic drugs, actually they may be used. Anti-chamber drainage implants such as Cooper's implant and Ahmed valve, Ahmed glaucoma valve, all these things, they may be after. So see, this is the neovascularization, and this is actually the neovascularization of the iris, rubeosus iridis. Okay, and ectropia and uvea. This is another thing actually we see, and this is actually the early angle neovascularization. This is all actually. Okay. So pseudo-exfoliative glaucoma this is another entity which we commonly see in the routine practice. So deposition of exfoliative material on the iris or ciliary body or capsule of the lens and joints. This is actually a dandruff-like material which we see on slit-lamp biomicroscopy examination. So etiology, it is not correctly known. Okay, and degenerative changes in the anterior uvea, particularly ciliary region, may be the cause. And flakes actually they get collected in the angle of the anterior chamber, and that gives rise to actually a raised intraocular. So usually it is an open angle. Okay, so this is this dandruff-like material in the pupillary border. This is pseudo exfoliation, and this is again over the lens is pseudo exfoliation. And here actually you see the white matter, white deposits. This is also pseudo exfoliative material. So the clinical features. So whenever you examine a patient of pseudo exfoliation, you see the flakes of pseudo exfoliation, dandruff-like material on the anterior capsule of the lens, and also the pupillary border. Pseudo exfoliation of the pupil, and the pupil is actually very recent and it will not dilate. So that's the reason pseudo exfoliative. Whenever there is pseudo exfoliation, we find it difficult actually to do the cataract surgery because the pupil will not dilate, and we have to have actually pupillary dilators to do the cataract surgery. Okay. Pseudo exfoliation ring and the anterior capsule can also form. We are seeing this thing, and what you see is actually whenever the IOP is usually raised, and the angles when you examine by gonioscope, it will be open angles. Okay, patients with pseudo exfoliation of the lens capsule have a high chance of developing a primary open angle glaucoma. And secondary rise of IOP after cataract surgery. This is actually in a glaucoma in aphakia, pseudophakia. Either it can be because of the surgery or its complications. Commonly seen after surgery in the pediatric cataract and following anti-chamber IOL. And rise of IOP is due to viscoelastics. So whenever actually you are doing a cataract surgery, at every step actually we inject viscoelastic material, or sodium hyaluronate, whatever it is. So what happens is actually this viscoelastic material, unless you aspirate it completely at the end of the surgery, this goes and actually clogs the trabecular muscle, and it gives rise to actually a raise in intraocular pressure in the immediate postoperative period. And second cause can be a distortion of the angle structures due to tight lumbar sutures. Of course, nowadays we are not using sutures, both in small incision cataract surgery and phacoemulsification. But previously, when it's a conventional extracapsular cataract extraction or intracapsular cataract extraction, we used to put nearly about 5 to 7 sutures or 8 sutures, and if the lumbar sutures are very tight actually. So this can cause actually distortion of the angle structures, and that can give rise to a raised intraocular pressure and severe postoperative reaction in the immediate postoperative period of acute iritis with grade 4 cells and all these things, or a toxic anti-segment syndrome. All these things can give rise to a plasmid aqueous, which again is difficult for it to go through the trabecular muscle and see its drainage into the circulation and the episcleral veins and usual conventional outflow, and then actually there will be a raised intraocular pressure in these cases. Number is, suppose if there is a hyphema, so hyphema, the blood actually, it can clog actually the trabecular muscle again, and that can give rise to raised intraocular pressure. Suppose if the vitreous is there in the anterior chamber, it can cause a pupillary block, and that can give rise to actually raised intraocular pressure. A retained cortical material can cause actually a toxic uveitis and secondary glaucoma in these cases. And aphakic malignant glaucoma, ciliary block glaucoma, is another cause actually for raised intraocular pressure in aphakia or pseudophakia. Okay. A chronic rise of intraocular pressure is due to secondary angle closure, maybe because of the pupillary block, and due to flat anterior chamber. In the immediate postoperative period, if there is a flat anterior chamber, we'll have to think of 3 causes. One is a wound leak, and second one is actually a choroid attachment, and third one is actually a malignant glaucoma. Okay, so this is in chronic cases. Suppose if there is a flat anterior chamber due to long-standing wound leak, so this causes actually the positional and cynical angle closure in the angle, and that gives rise to actually a raised intraocular pressure. Undiagnosed pre-existing primary open angle glaucoma, which was not diagnosed at the time of actually surgery, cataract surgery, that can give rise to a raised intraocular pressure. And high responders of the steroid, actually, there can be steroid-induced glaucoma for the usage of actually steroids locally for about 4 to 6 weeks. And there can be an epithelial growth and fibrous derm growth in case of after the late postoperative complication of cataract surgery, and that can give rise to a raised intraocular pressure. Treatment is actually we try to do reduced intraocular pressure with medical management, and trabeculectomy with antimetabolites can be done. And if it is still in calcitrant case, and such cases actually we do actually drainage procedures such as Glaucoma-VI and toothless stems and all these things we use. Steroid-induced glaucoma is another thing actually. It usually occurs in high responders of the steroids. There are nearly about 65% of the 60% of the population. They are non-responders. About 35% actually they are moderate responders, and 5% actually they are high responders. In high responders, only a topical systemic periocular steroid treatment can cause a decrease in the aqueous outflow and raise the intraocular pressure. It's usually genetically predisposed. Usually after 4 to 6 weeks of topical steroid therapy in normal population, about 5 to 6% develop a raised intraocular pressure more than 30 millimeters of mercury. All patients, they have only a primary open angle glaucoma or non-intensive glaucoma develop after topical steroid therapy. Okay. So the clinical features in steroid-induced glaucoma, usually these people, they are asymptomatic, they will not deny it. The routine examination, we see actually there is a raised intraocular pressure, white paleness eye with an open angle. And when you examine actually the fundus and evaluate the disc, so you see optic disc cupping and Humphrey visual field analyzer will reveal actual visual field defects. And intraocular pressure measurement with Goldman applanation tonometry will reveal actually elevated intraocular pressure, and decreased outflow facility will be there, and acute presentation can occur if IOP is very, very high, say about 460 millimeters or so. Theories of raised intraocular pressure, they may not ask, but if you are too good actually in the examination, we may ask you in the orals as a deposition of polysaccharides in the trabecular meshwork, suppression of phagocytosis, and also abnormal accumulation of dihydrocortisols in the trabecular cells, and steroid inhibits synthesis of prostaglandins and E and F, that also gives rise to actually raised intraocular pressure. So the clinical features, they resemble actually primary open angle glaucoma. So where the eye is quiet, and when you examine the intraocular pressure is rise, and there will be glaucomatous cupping, and visual field defects will be there, and it develops some 4 to 6 weeks after the initiation of the steroid therapy, either parenteral or periocular or local. So management of steroid-induced glaucoma is either judicious use of steroids whenever in patients with, say, high responders, if you know that, and there is family history of steroid responders, that also must take into consideration. And regular monitoring of IOP after starting actually the steroids in almost all the individuals. Medical therapy will have to be done, can be given to these people to reduce the intraocular pressure from high levels to the near normal levels, and a filtration surgery in the form of trabeculectomy can be done to treat these people. And ciliary block glaucoma or malignant glaucoma is another thing which can be given as a short note for you people. It occurs as a rare complications of any intraocular surgery, either during the surgery or immediately after surgery also can occur, and occurs in patients with PACC, primary angle pressure glaucoma, operated for peripheral iridectomy or filtration surgery, that is trabeculectomy, or after laser iridotomy. So these things, after these surgeries, actually it's more common. Malignant glaucoma can be phakic or pseudophakic. Here actually what happens is actually the ciliary process, they rotate forward. Okay. So that again there's so the glaucoma is this ciliary block glaucoma is characterized by markedly raised IOP, and shallow or absent anterior chamber will be there. Mechanism of rise is either cilioventricular or ciliovitriol, or cilioventricular or ciliovitriol. These two things, these two type of plaques will occur. As I told you, the ciliary process, they rotate forward and they block, actually they get attached to the lens, or phakic cases. And in case of pseudophakic cases with the IOL, and suppose in case of actually aphakia, or the anterior hilar phase of the vitreous actually gets attached, and that blocks actually the vitreous, the aqueous to come into the anterior chamber, and it gets collected as pockets into the vitreous. So clinical features are persistent flat anti-HMR following intraocular operation, usually those 3 operations which I have already mentioned, and markedly raised intraocular pressure in the immediate early post-operative period. And when you do a negative CDH test, so because there is a shallow anti-HMR, we have to actually differentiate it from a wound leak. So the CDH test if you do actually, it will be negative and unresponsive or aggravation by myotics actually. This is seen actually in type of the ciliary block glaucoma. So this is how actually where this is the block and this is actually the block. And these are the pockets of aqueous which they get collected. Okay, so the management of case of ciliary block glaucoma with 1% atropine drops disguise actually the dilatation of the ciliary ring, and nextazolomide 250 milligrams TID can be given. Intravenous mannitol 20% can be given 1 gram per kilogram body weight. It should be given in a fast in half an hour. 0.5% tibulol maleate should be given. Myotics normally we don't give. And surgical therapy is posterior sclerectomy. We do posterior sclerotomy we do, and aspirate actually the vitreous pockets. Okay. So these things, this is actually posterior sclerotomy we have done, and we aspirate actually the aqueous which is corrected in vitreous. So glaucoma is associated with intraocular hemorrhage, red cell glaucoma, hemolytic glaucoma, ghost cell glaucoma, pigmentocytotic glaucoma. All these things actually they are they do occur. You can mention the description. You need not actually know the very details of it. Traumatic glaucoma can be either due to following corneal perforation or following blunt injuries. So the mechanisms are whenever there is a blunt injury, there can be inflammatory glaucoma due to iridocyclitis. A traumatic iridocyclitis can occur. And intraocular hemorrhage in the form of actually edema or vitreous hemorrhage can also give rise to raised intraocular pressure. And suppose if the lens is actually rather ruptured, so that can give rise to swollen dislocation lens, can also give rise to lens-induced glaucoma. The adherent glaucoma with peripheral anti-cyanic can give rise to raised intraocular pressure. Epithelial or fibrous downgrowth, epithelial ingrowth or fibrous downgrowth can give rise to angle recession. Is another thing which is caused by injuries, and that can give rise to actually glaucoma or raised intraocular pressure. Glaucoma associated with intraocular tumors is another thing actually which we see commonly, and so the commonest tumors which we come across are melanoma, iris or choroid or ciliary body, and retinoblastoma is a malignant tumor in the infants. And these things actually they cause a trabecular block. The tumor cells can go and block actually the trabeculum, and the neovascularization of the angle can also occur in the tumors, and venous stasis because of the pressure of the tumor's mass over the veins, and forward displacement of lens iris diaphragm by the tumor in the posterior segment can also give rise to peripheral positional lateral cynical anti-cynical angle closure and giving rise to a raised intraocular pressure. Treatment normally in case of actually all these things for glaucoma-VI actually there are different types of modalities of management, and this thing we come to that actually when we talk about actually intraocular tumors, and usually enucleation will have to be done in most of the cases. So the congenital glaucomas we have already seen. We have talked about it, and so to recall a little about actually management of the glaucomas. So the medicines, lasers, and surgery medicines usually the beta blockers, alpha adrenergic agonists, and also latanoprost, and the systemic parenteral drugs we give are mannitol, glycerol, and we have acetazolamide, carbonic anhydrase inhibitors. All these things will be given, and a target pressure will have to be actually fixed in each case. And suppose if one drug is not effective, we give actually another a combination of different action of mechanism of action. And it's not two drugs also, they are not effective. Sometimes we add three drugs and they are not actually effective. In such cases, we may go in for actually laser trabeculoplasty or laser iridotomy, depending upon actually the type of glaucoma. And in all these cases, actually, you have to take family history, extent of damage to the optic disc, and also visual feeds, and you will have to document everything. And medical management, we have already talked about beta blockers and all these things. And surgical management, goniotomy, trabeculotomy, peripheral iridotomy, visualizing operations, pre-filtering surgeries, and guarded filtering surgeries, trabeculectomy. And free-filtering surgery operations, actually, whereas we are not doing artificial drainage operations and cyclodestructive procedures are also done. And free-filtering operations are Ehlers sclerocorneal profiling and pulse sclerotomy, space thermosclerotomy. These things, actually, they are not being done nowadays if they are of only surgical historical interest. And trabeculectomy, I have already shown you actually the various videos. And so the indications and everything will tell you again sometime. This is actually various figures where how we do actually trabeculectomy. And complications of trabeculectomy, the early complications are shallow anterior chamber, hyphema can be there, iritis can be there. Late cataract can occur, blood failure, phlebitis with blood leak, and endophthalmitis can also occur. Filtering blood is a diffuse elevation of the conjunctiva showing microcystic changes in the limbus. Okay, and use of antimetabolites. Usually, the antimetabolites we use are mitomycin and also perfluorouracil. We'll tell you how we use it. The treatment of congenital glaucoma, already we have talked about it: goniotomy, trabeculotomy, trabeculectomy. And peripheral iridectomy, I'll show you the video. Cyclodestructive procedures for absolute glaucoma, actually, we have cyclocryotherapy and laser cyclodestruction and cyclophotocoagulation. So cyclophotocoagulation, again, it can be actually transpupillary or transscleral cyclophotocoagulation. Anesthesia is always peribulbar, and lid separation and cryoapplication of 3 millimeters from the limbus. Freezing temperature is minus 80 degrees for 1 minute. At 180 degrees we do it, and we repeat it again after 3 weeks actually, in case it is not this thing. Okay. Now we go on to actually show 2 slides, 2 videos, and this is actually last surgical laser iridotomy.
The clear cornea incision is outlined. A clear corneal bridle suture is applied just anterior to the insertion of the conjunctiva, passing the needle intrastromally. A 2 to 3 millimeter clear corneal incision is made. The blade is made to incise 2/3 of the corneal depth. A 15-degree sharp blade is used to create a paracentesis. The anterior chamber is entered without injuring the iris. The iris is gently grasped and exteriorized. The iris is regrasped and the iridectomy performed. The cut iris is inspected for the presence of the posterior pigmented layer. To return the iris, the wound may be stroked towards the center of the cornea, or a stream of fluid directed into the wound. Note of patent iridectomy.
See, this is patent iridectomy.
The wound is closed with 10-0 nylon, and the knot buried.
This is patent iridectomy, which was done. Okay, you see a hole in the iris. Next, we are going to see
A clear corneal bridle suture is applied just anterior to the insertion of the conjunctiva, passing the needle intrastromally. A 2 to 3 millimeter clear corneal incision is made. The blade is made to incise 2/3 of the corneal depth. A 15-degree sharp blade is used to create
a standard Ahmed Ceton implantation. I like to mark the supratemporal quadrant with these dots. It helps to delineate the area to be dissected, but it also is really helpful when we're trying to bring the conjunctiva back together for our closure. You can see I'm very careful using only blunt dissection here and trying to conserve every millimeter that I can of the conjunctiva to help us with our closure. You never know when that's going to be too handy. Here you can see that there's a failed bleb superiorly, so I'm taking great care to avoid that area, yet still leave enough space to implant the Ahmed. I like to just use blunt dissection to identify the pocket for implantation, which is just beneath tenons, and then I like to use a curved Stevens scissors here, mostly to just bluntly dissect that area. I think blunt dissection is your friend here and helps keep us from getting into trouble. I don't always hook the muscles here, but here I'm trying to make sure there's enough space, and I use this marking pen just to identify the insertion of the lateral rectus here. I'm applying gentle cautery here, mostly to help improve our view. We're careful to avoid excessive cautery here, which can cause scleral thinning and make suturing less predictable. Here's an important step with every Ahmed, which is priming the tube. You also want to feel for a slight pop as the valve mechanism opens up. Here you can see we're using a caliper to make sure that we're at least 8 millimeters behind the limbus. Here's a little trick I like to use when securing the plate to the sclera, and that is to just flip that needle around and back it through the eyelet, which I find a lot easier. With a silicone plate like this, it's easy to get the needle embedded within the material itself, but when you use this technique, it passes through very easily. We tie both sides and then rotate the knots. We create a bevel up configuration for our tube, and then we fill the anterior chamber with viscoelastic. Typically I'm using a dispersive viscoelastic here, which I just leave in place, which I think helps to slow down the pressure lowering and makes it safer. Now this is a very important step in terms of determining the final tube position and configuration relative to the cornea and the iris, and so I try to just go straight in, straight out here without flaring the edge, and try to make my hands move in super slow motion. Here I'm noticing that the bevel is just slightly to the side, and you can adjust that slightly by grasping the tube and twisting as I'm doing here. And then I'm relatively happy with its position. I like to use a cross stitch fairly close to the sides of the tube and with long bites, which helps to impede the lateral movement and any dolphining or bulging up of the tube as it's healing into place. Here in our center, we're still using donor cornea. You can see that I've trimmed it so that it will cover the anterior extent of the tube. The coverage in cosmesis with donor cornea is just excellent. You can see that I'm taking care to line this up and bury the knot, which I think helps with patient comfort. It can be a little challenging when there's a superior bleb to get the patch graft over the tube and still have enough space, but we're able to do it here. Again, burying the knots to try to improve patient comfort. And now I'm just trying to hold up the conjunctiva to see how it's going to line up, and then I perform what I call a wing stitch, which essentially is a horizontal mattress suture. You can see that I'm going from inside to out and then outside to the middle across. I like to take a good corneoscleral bite here with this bite to help anchor the conjunctiva and make it more resistant to any potential rubbing or frictional forces. And then you grasp both ends, and I think it's important to pull in line with the incision here so that that knot is fully buried. And the end result is that you have a strong horizontal mattress stitch which is buried within the incision, and the suture is leading out of the posterior end so that you can run it like this. And here I'm simply using a running baseball stitch to close that radial incision. When I'm suturing next to an existing bleb, I do take slightly smaller bites than usual just to ensure that that area is watertight. And here you can see we've done the same thing on the other side. In the end, this is covered quite nicely. This patient has done well. Thanks for watching. Good luck.
Glaucoma. Okay. With this, actually, we complete the topic of glaucoma, and repeat actually the primary open angle glaucoma and also primary angle flow-chart disease. So they are important for you people, and it can be given as an essay question. And the rest of the things I told about short notes which will be given. And read well. If you have any doubt at any time, you can as well call us. Okay. If you have any doubts, you can as well tell me. Shortly, I think maybe in a day or two, I think we'll put it in the concerned area and you'll be able to see it. And once again, I congratulate Meena and also Murthy for dropping this thing. Okay, all the best.